All right, on-scene termination. So this did not change to any degree for the most part. So still we're doing adult only. Here I did change this number. So this number did say 20. All the published standards are actually 15 minutes. We did this when we first started to give us a little cushion. But 15 minutes is actually what's proven in the literature. So if you can confirm the downtime is greater than or equal to 15 minutes, and you have either a systole or a non-shockable rhythm, you can stop. So don't feel pressured to run a code that's going to be unsalvageable. I mean, these folks have a less than a 0.5% chance of survival when you meet under those conditions. So as aggressive as we want to be with resuscitating viable people, I want to be just as aggressive in not resuscitating non-viable people.
And I don't think that's a disgrace. Sometimes you get certain people that want to lose somebody. You got somebody getting that 15 seconds and you call it. I think let somebody die and be.
Correct, right.
Opposed to somebody coming in and want to take 20 seconds still or armchair quarterback and why they start CPR.
Correct, right. And that's why I like putting it in a protocol, because it protects everybody. It protects everybody's decision making, right? Everybody's going to die. We're not ever going to save everybody. There's a few people we can save for a few years, but everybody's ultimately going to die. But if you can confirm, and sometimes it's hard to confirm downtime. So when in doubt, I want you to do what's going to make you sleep better at night, because that's exactly what I do. If I got to lay awake and think about something I did all day, I probably made the wrong decision. So you do whatever makes you sleep better at night. But if you can confirm that they've been down for longer than 15 minutes and they don't have a shockable rhythm, there's no reason that is perfectly acceptable not to start CPR. All right, so that part did not change. I just changed the number from 20 to 15 to make it actually standard with the science. All right, so if it's no when we're doing CPR, so you got first responder, EMS, BLS, ALS, and you've gone for more than 20 minutes, and if your end tidal CO2 is greater than 10, we'll continue. But if we've done good, effective CPR for 20 minutes and our end tidal CO2 is less than 10, that person's not going to survive. So I would stop. So you're absolutely can stop at the 20-minute mark if you've done, make sure it's got to be good quality CPR. And if it's good quality CPR, they don't have an end tidal CO2 above 10, they're not going to survive. So we can stop there. If we have gone 30 minutes and we've continued to do good CPR, so this is a change. So this is a big change. So once we get to that 30-minute mark, so assuming that the end tidal CO2 is above 10, we're going to continue our normal cardiac arrest pathway. When we get to 30 minutes, though, if we still got end tidal CO2 above 20, I want to change to an endotracheal tube, okay? So for a couple reasons. One, we know that early attempts at intubation actually decrease your chance of survival. But once we start getting toward the 30-minute mark, if we still got good perfusion, then we are at a point where hypoxia is probably evident inside the body. So I do want to switch over to an endotracheal tube for a couple reasons. One, so we can get more accurate end tidal CO2 data. So at least a few studies have done through a King airway. End tidal CO2 is pretty accurate, but it's most accurate through an endotracheal tube. And so I want us to place an endotracheal tube so we'll have absolute better chance at sampling end tidal CO2 to give us better decision making. Two, at this point, if we're still doing CPR, we probably do need to switch over to a more secure airway. However, if the airway's working fine and you look at this person and you say, wow, this person's going to be really hard to intubate, then don't try it. So if you believe that you're going to have a lot of difficulty and you don't have any trouble with the airway that you've got in place, don't, because what's going to happen is you're going to fall back into some of our old habits where we become too entrenched in trying to intubate and we stop CPR. Now, having said this though, you got 10 seconds. So whoever your partner is, as soon as you stop compressions and get ready to intubate, tell your partner, you start counting down from 10. When you get to 0, you get back with a bag valve mask and wait till the next cycle and try it again. So do not wait more than 10 seconds. Do not interrupt compressions because that endotracheal tube is not going to save them. Compressions is what's going to save them. So you got 10 seconds. That's it. Put the bag valve mask on. Reattempt at your second 200 cycle compression. All right, so that's a big change. Any questions about that? So try to get that head in the right position. Be ready to intubate. You got 10 seconds. Go, Christy. Absolutely. Sure. Yeah, absolutely. Yeah, absolutely. 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 Perfectly acceptable. So, the king is, you absolutely can run a bougie down. It can be a little hard sometimes, but yeah, you can do it. I would even tell you to give you a little practice at the bougie is if you remove the king airway, that's a good time to use the bougie. Especially if you know it's somebody that looks like it's going to be an easy intubation. You should always use a bougie on a few people that you know is going to be easy, so you know how to use it later. You don't really want to be in the weeds when you pull that thing out. So, all right, any questions about that? Yes, sir.
I guess the only other question I have is if we choose not to stop compression, we've done this before, to put the maintaining on at 15, keep compression going, pull it, then you got back to the 30, 45 seconds to work and all that. Is that still acceptable as long as we don't stop compression?
Yes. Yeah. So, like if you put a nasal cannula on, crank it up wide open, and using a bag valve mask to ventilate, is that what you're asking? Like so you couldn't get them intubated?
No, we're getting ready to. We're going to swap the boots.
Okay.
We're going to swap the.
Swap the king. Yeah.
Swap the king. Keep compression going.
Yeah.
Put the nasal cannula on them. Compression continues. Pull the king. You're still doing compression because they never stop. Then you just go. You've got time and pass it to.
Sure. Yeah, absolutely. I mean, if it's, trying to intubate somebody during compressions is always harder than it seems. But so what I would say is you got 10 seconds no matter what. So I would try to shoot and give you the best chance of intubating as quickly as possible. So I'd probably stop. Because honestly, if you're ready to go, if you got the patient, got the head elevated, got the external auditory now to the sternal notch, you got your blade, you're ready to go. I mean, if you've got everything in position, I mean, you're probably going to get this in 5 seconds or less anyway. So, but if you've got the nasal cannula in place and you don't get it, no big deal. Just get back on the chest with compressions and use a bag valve mask along with the oxygen cannula. If you've got enough tanks to set up, if not, just have your tank hooked up to the bag valve mask, and just ventilate with a bag valve mask until your next cycle, to where you can try again.
So, just for clarification, you're saying even if we continue with compression and we try to intubate, you still want us to limit to 10 seconds?
Yes, I would still want you ventilating every, if you're doing compressions, you got 10 seconds to get that intubation. If you can't, stop it, continue to ventilate with the bag valve mask, and then regroup for the second attempt when you get back to the next 200. Yeah, don't keep, because honestly, what's going to happen is whoever's doing those compressions is going to try to make it easier for you. They're going to slow down. They're going to not press as hard. There's going to be a change, and I don't want us to slip back in our old habits, which we've all done. So I do want to change to an endotracheal tube, and the other reason is it'll give us a little bit more practice with doing intubation. That's not the sole reason. The real reason is we get a better end-tidal CO2 sample, and we got a secure airway. But one of the nice side effects is it gives us an ability to intubate a little bit more, which none of us get that much practice at intubating. Even I don't, because the residents intubate everybody, so I don't get to intubate anybody anymore. All right, so that's a big change. Big change. The main thing is do not let it interrupt your good compressions, because we have an excellent survival rate now, and we don't want to slip back to a bad survival rate, right? We have an excellent survival rate thanks to you guys. All right, so 30 minutes. We're going to change to endotracheal tube. If our end-tidal CO2 is greater than 20, we're going to keep going. If after 45 minutes you still got end-tidal CO2 greater than 20, call me. Call me and we will make a decision about what to do, because I don't know the right answer. Nobody knows the right answer. And we'll talk about, did we ever have a return of spontaneous circulation? Did we ever have any pulses at all? And how old is the person? Underlying medical problems. So we will figure it out based on that point. So once you get to 45 minutes, call and we'll make a decision together, because nobody knows the right answer. Call me, yeah. Because you're going to get the wrong answer from the hospital. No offense, no matter which one you call. I went through this with Stokes, and we got lots of bad advice from the hospital. Both, all three that we called, we got bad advice. So, and that's not that I know any more than anybody else. It's just folks who have end-tidal CO2. End-tidal CO2 is not routinely used in the hospital, and folks don't completely understand it or use it that much to prognosticate in CPR. And I'll tell you, we had a couple of cases where we actually transported a few people who had end-tidal CO2 greater than 50, and as soon as they got to the hospital, they immediately stopped the CPR, which I would have never, ever stopped CPR with an end-tidal CO2 above 50. So again, you know, it might be 20, 22, 25. It's been that way for 45 minutes, and they're 70 years old. You know, we just will together make a decision about stopping or going on. And again, a lot of times by the time you get to this point, as we've talked to the family's pretty much made it known whether, you know, and honestly by that point they've gotten to the point where they want to stop it too. It's been my experience. So if we get to that point, that's a pretty prolonged code. So just call me and we'll make a decision about if we're going to keep going, if we're going to stop. The good thing is when we get to that 30-minute mark and we switch over to the endotracheal tube, we'll know we got a good sample of end-tidal CO2. I'm pretty confident we got a good sample with King Airway, but I know it's going to be a good sample with our end-tidal CO2, with our endotracheal tube. Sorry.
If you look at the difference with the iGels over the last several months compared to how it was with the Kings, is that any different?
Well, the only difference is that's all they use now. Right. So we still have Kings on the truck, but they have not, and I haven't said anything. I haven't made any recommendations whatsoever. We trained them, we put them on the truck, we hadn't used the King Airway since. So they prefer the iGel. So I know we've only had one really obese lady that we had some trouble with seal, and iGel tells you that if it's a morbidly obese patient, you may have trouble with seal. That was overcome simply by pushing it down a little bit and then taping it into place when they pushed it down. Because the little strap that it comes with iGel is a little flimsy. So now we've changed to where we just tape them down like an endotracheal tube and we don't use that strap that comes with it. But yeah, so they just preferentially go into the iGel. We still have the Kings though, but I think now everybody likes it so much better. That's what we're going to do as we exhaust the supply of King Airway. We're going to switch to iGel. The other benefit is it goes all the way down to neonate, so you get more pediatric sizes. You don't any under 12 kilograms King Airway, they don't have anything. So iGel's got some pediatric. All right, the back side of the termination did not change. There might be some words in there. I kind of cleaned it up a little bit, but nothing significant changed on the back side. All right, so any questions about CPR at all? Our survival rate is awesome. So you're doing a good job. But any questions? If it's less than 20, you can stop. Yeah. Yeah, yeah. And then we'll make a decision. Yep. Correct. Yep. 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 Yes. Yeah. Yeah. All right. And well, one comment about I don't care what you guys use for the iGel. I don't care. It's either one. They're both good airways, so it's whatever folks prefer. I want you to use the equipment that you prefer, so I don't care. Yes, sir.
So are we letting the families override the DNR still on scene or not? Or are we doing it case by case now? Like, you know they have a valid DNR
Sure.
for a cancer patient, and they
Yeah.
say, well, I still want you to resuscitate.
Yeah, so very good question, and it's hard because that happens every day in the hospital too. And that's one of those things where I think you gotta have to do a hybrid. So, and all that boils down to is you just gotta talk to people. So I would start CPR, and I gotta tell you, I don't know why, but every single person has a DNR and the family overrides it. That's exactly the person that you're gonna get back. I don't know why that happens, but that's a person you're gonna get back. So I would start CPR and I would do it effective just like we do. I would not do a show code. There's no place for that. If we're going to do it, it's absolute 100% do it, and then talk to the family. And then try to figure out what it is, why they're trying to make that, why they want that decision. I mean, basically it boils down to guilt. I mean, folks don't want to make that call for their own family member. I understand that. I wouldn't want to make that call for my family member either. So, but then you're just reminded of that. You know, when Ethel was awake and alert and could make her own decisions, she made the decision that she did not want to be resuscitated. So and I just remind them, so she took that burden off you. So that's things that I tell folks. She took that burden away from you. So you don't have to make that decision. She made it for you. She don't want to be resuscitated, and she took that decision. She took that hard decision off you so you wouldn't have to make it. So that's kind of some of the things I say when we get started. But I'll continue because, you know, folks got to sink in. You know, they got to have a little time to process. And then honestly, once most folks watch what happens in a CPR, you know, most folks, again, they tend to want to stop it sometimes before we want to stop it. So I think once you figure out the underlying issue and remind them that they don't have to make this decision, that Ethel or Larry made it for them, you know, most folks come to terms with that. Sometimes they don't, though. Sometimes they don't, and then you know, I would continue the code. I've done it many times. We continue it until we get to a point where we say, so now we're done. And the great thing about this is, you know, we got more tools now. We can use end-tidal CO2 connected with time, and folks, you know, it's not just me walking up to somebody and say, you know, we've done it and nothing's happening. Now you can tell them, we've done it 20 minutes. They don't have any end-tidal CO2. The number should be above 20. Theirs is only 5. That means they're not. So, you know, people tend to respond better if they got some hard facts and hard numbers. But that absolutely happens all the time. Happens in the hospital all the time. Absolutely. And many times it's a family member that lives away, that had no involvement in the care. Because most folks who've watched somebody dying in a process and they've got a DNR, they are relieved. I mean, there's some relief there that folks aren't suffering. It's the person that hasn't been there, feels guilty because they weren't involved. It's always that person that shows up, you know, that it gives us the most trouble sometimes. But again, they're just trying to process this too, and they just need a little time to get through it. But a little effective talking and trying to figure out that usually will get us to the point where we can stop and everybody feels good about stopping. So, yeah, good question. Very good question. All right, any other questions about cardiac arrest? We'll move on from cardiac arrest. All right, allergy and anaphylaxis. Not a whole lot changed on this protocol, except we added a couple of caveats. So mild is skin only. So if you've only got a reaction that's skin only, then our Benadryl, and our Zantac. Moderate, 2 or more body systems. So if they've got shortness of breath and they got a rash, that's what? Shortness of breath and a rash we call anaphylaxis, absolutely. So if it's 2 or more body systems, it's anaphylaxis. So it's at least moderate. Epinephrine, always on top, first drug. We took out the auto-injector. They're very expensive. We've not been using auto-injectors for a while. So but statewide, we took it. People can still use the auto-injector, but you don't have to use the auto-injector. Epinephrine, 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 epinephrine. All right? That's really all you have to remember. These things, Benadryl, Zantac, Solumedrol, nobody should die itching, right? That's the only reason you give those drugs, right? Epinephrine is the drug. All these other things, completely fine. They block histamine. They make people more comfortable. They get better. But epinephrine, if you get to the moderate and have a very low threshold. So epinephrine's not going to kill anybody. The only thing that's going to kill them is that anaphylaxis that we don't treat. All right, you remember I told you guys a few months ago, I had a case in Stokes where a guy mowed over some yellow jackets. He was going to be smart. He went out at dusk. He took his gas can. He was going to go kill them. They were waiting on him. They stung him about 100 times, and he makes it back to his trailer. He collapses on the back porch. Wife finds him. He's syncopized. She starts the dispatchers get him to start CPR. I doubt he ever lost a pulse, but he got CPR. So first responders get there. He's starting to wake up now. EMS gets there. He actually got better. I don't know how this guy got better, but he actually got better. By the time he got to the hospital, he was a little tachycardic, but he had no symptoms. He didn't have any hives. He didn't have any shortness of breath. He didn't have any nausea, any vomiting, no itching, nothing. He just had hypotension, and he had syncope. That's anaphylaxis. So we didn't give epi. I gave him epi at the hospital. I mean, he'd already got better, but if you don't get epi, then there's a chance. Those are, even though it's a low percentage, those are the ones that can have that secondary reaction within a few hours later. So remember, if there's some sort of antigen, if there's a bee sting or peanut or something that might be an allergy and somebody has syncope and hypotension, assume that they're anaphylactic and give them epinephrine. Because that really was a great case, because this guy had nothing but hypotension and syncope. All right, so we move over here. It's the same thing. If it's severe, 2 or more body systems with hypotension, or just isolated hypotension, epinephrine, 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 and then you can give all the other stuff after you've given epinephrine. So, and also once we get down here, if somebody is really severe and they're not responding to that, so how much epinephrine can we give? Every 5 minutes until we run out, right? Or we call somebody else and we keep giving epinephrine. If you've got somebody over in this category that's severe hypotension or just isolated hypotension and they're not responding to IM epinephrine, remember, if they're really hypotensive, even if we give it intramuscular now, the ability for the body to absorb it still might be delayed. You know, sub-Q was awful, but IM still may be bad if they're hypotensive anyway. So call me and we will give some IV epinephrine. All right, so remember, and I'll talk about it now, that's our other push dose pressor. We'll mix it very similar to phenylephrine. We'll take 1 milligram of epinephrine. You put it in a 1,000 cc bag, just like we did with the neosynephrine or the phenylephrine, and that gives us a 1 mic per cc. Right? It's 1,000 micrograms put in 1,000 cc, so it's 1 mic per every cc. Pull up 10 cc's, you got how many mics? 10 mics, right? So you got 10 mics. So you can give 2 to 3 mics every 2 to 3 minutes, just like we would with our push dose pressor. And honestly, you don't really need to call me, because if they are hypotensive or have isolated hypotensive not responding to IM epi, your hypotensive protocol has that you can give a push dose pressor. And that. So feel free to call me. I'm happy if you call me. But you don't necessarily even have to call me, because I forgot it's in our hypotensive protocol. So that actually covers you without calling me. So. Well, no, they would be anyway. So because the hypotensive protocol actually has four things, right? So one of those is distributive, which would be anaphylaxis. So they really are together. You know, the old way I think I had on the back where we could give IV epinephrine, but we were going to mix it in a little different way, and it's a little bit more complicated. The push dose pressor is actually the easiest way to mix that. So if they are persistently hypotensive and you've given a couple of IM doses of epinephrine, you call me. But if you don't have time, you don't have to call me. Just go to the hypotensive protocol and give push dose epinephrine, 2 to 3 mics. It is amazing sometimes how these folks will completely turn around with just 2 to 3 micrograms of epinephrine IV when they didn't respond to 0.5 mics IM.
Is that the new hypotension program?
Yes, because the current one does not have push dose pressors, right? Yeah, but the new one will have our phenylephrine and our epinephrine mixed. To an awake patient, no. No, because you would be giving 1 milligram of epinephrine. So that you'd be given 1,000 micrograms, and what we want you to give is 2 to 3 micrograms IV. So, so if no. The only thing to give the caveat, you already said no. That has been done before. And honestly, most of those folks did just fine because they were so sick that they needed the epinephrine. But from a safety standpoint, it's much safer to give them 2 to 3 mics every 2 to 3 minutes rather than giving them that one big, because that's the cardiac arrest dose, right? You know, very good question, absolutely. And it has been done before, but they are most likely to get all the bad side effects from that drug. Not that it won't save them and they'll be happy and they can complain about the side effects later, but that's the chance that you give them more bad side effects. You give them more of the risk, even though they would still get some of the benefits, they'd be getting more of the risk, especially in older folks, you know, over 50, somebody with underlying heart disease, be a little bit more risky to do that. Yeah, I'm almost 50. All those guys almost 50. I'm right at 50. I'll be there in a few weeks, a few months. So not much changed here. Remember, I still got the definition of anaphylaxis. Acute onset of illness, minutes to hours, with skin involvement, hives, erythema, itching, or angioedema, plus dyspnea, wheezing, stridor, hypoxia, or hypotension, poor perfusion, shock, incontinence, or syncope. So all of these things would tell you that you've got anaphylaxis. And then number 2, same thing. You've got acute onset of illness in 2 or more body systems, and then acute onset of illness minutes to hours with hypotension, poor perfusion, syncope. Not much has changed here. So I'm actually going to take this out. I'm glad I remember that. So I said that 1 to 100,000, I'm actually going to take that out because we're covered now in our push dose pressors under hypotension. So that I'm going to take out. So ignore that. I'll take that out. The only other things that have been introduced to the protocol is for angioedema. Remember, angioedema is swelling of the face, tongue, mouth, posterior pharynx. It's all up here. And it can be caused by blood pressure medicine. So all the ACE inhibitors, anything that ends with an IL, like Prenavil, lisinopril. Lisinopril is the most common. So, and people can take that drug one day, or they can take it for 10 years. And there is absolutely no rhyme or reason as to when they're going to have angioedema. Not that they will, but angioedema, when it occurs, there is no rhyme or reason. They could have taken that medicine for 10, 20 years, and all of a sudden, boom, their lips start swelling up. You don't see that a lot. We see that a lot in the emergency room. For some reason, people don't call EMS when their airway is swelling up from that person. I don't know why. If my tongue's swelling out of my head, I'm probably going to call somebody that can take care of my airway. But for some reason, they don't necessarily, I don't see a lot of folks who come in with angioedema by EMS. Almost all those people come by car. So you guys don't get to see it that much. But it is real. And so for us, if it's a blood pressure-induced angioedema, we're going to treat it the same way we do any other allergy or anaphylaxis. So we had that patient, I don't know, we still have that patient with the hereditary angioedema. She moved? Where'd she move? Well, anyway, so she still could show back up in the county anytime. So we did have that patient. We talked a lot about hereditary angioedema, but the main thing is hereditary angioedema, none of the stuff that we give works. I give it to everybody in the hospital because it makes us feel better. That lady was carrying the antidote in her pocket and didn't tell us about it. So, we made the case that she needed to tell us that, and we'd give her her own medicine because that's actually what's going to make that better. All right, if that happens again, if somebody tells you they got hereditary angioedema, ask if they've got their medicine and if they've got it. I mean, remember this lady had a port, and she would access her port and then still didn't know that she had the medicine.
We had one that had a swelling in the eye. It happens every day for the past week or probably 2 weeks.
Yeah, it started about 6 months ago when I was in jail. Study life.
He is a avid drug user.
It'd be weird for cellulitis to kind of come and go like that. That could be an angioedema variant. Yep. I mean, any swelling of the face could be angioedema. Right. Yeah. Right. Weird. Yeah. Well, you think infection, but if it keeps coming back over and over, it makes it less likely to be infection. So, I don't know. It could be an angioedema variant.